I'm Congresswoman Brenda Lawrence, and I proudly represent Michigan's 14th Congressional District. I serve as the Vice Chair of the House Appropriations Committee, and I am a member of the Labor, Health, and Human Services Education Subcommittee, which funds federal health care programs on an annual basis. I've worked with my colleagues each year to support diversity, equity, and inclusion initiatives, and to enhance funding for federal programs working to address both health disparities and to
trees, bird, with you and your colleagues today in recognizing Chronic Disease Day, because this is very important to improving the health of Americans as well as
Dr. this year. We're very pleased to have as our guest Dr. Louis Sullivan, who is the president of disease
and health disparities, for having me open
much to all
health disparities. Thank you again for having me open this event and for the opportunity to join you all.
Thank you very much to all of you who have joined us for Chronic Disease Day this year. We're very pleased to have as our guest Dr. Louis Sullivan, who
My name is Justin Wilson. I'm really proud to have the opportunity.
Growing fan club. We appreciate you taking the time today to join us.
Thank you. My pleasure. Good luck to all of you.
Thank you.
Hi, Dr. Loretta Christensen. So great to have you here today. My name is Justin Wilson. I'm really proud to have the opportunity to interview you on behalf of Good Days and the Chronic Disease Alliance as part of our web. My name is Justin Wilson. I'm really
my opportunity to speak today.
Your great war appreciation.
And thank you all for recognizing April as Minority Health Month with this annual Chronic Disease Day Health Equity webinar. I am Congresswoman Lucille Roybal Allard, and in 19
that the laptop is positioned correctly. Yeah. It's wiggly because it's on I have it on 2 trays that I made out of wine corkscrew, wine corks. And so I'll try not to move it when I'm talking because, I use my hands a lot. So I'll use them out here, Is that better? Okay. All right. Well, that's all we want. Every time I touch this, it's going to wiggle. That's not good. You sure? Because I could try books instead of my corkscrews. All right, let me try this stack of books that I have as a second option. It's about as tall. Not as tall. Let's try one more. Gonna make it a little lower. Let's see. How's that? Not as wiggly. Yep. Better? There? Okay. All right, that should be better then. All right. See, and I can leave till like 10 till or something? Or are we waiting for other people for?
Thank you to the patient advocates and public health advocates with us today. It is my pleasure to welcome you to the annual Chronic Disease Day Health Equity webinar in recognition of Minority Health Month. My name is Congresswoman Nanette Diaz-Barragan, and I represent California's
3. Awesome, thank you. Yep. Awesome. Testing 1, 2, 3, testing 1, 2, 3, testing 1, 2, 3. You're welcome.
The audio is good, good. Yeah, I know. I know. A foot. Okay. We'll get. Okay, stop. Yeah. Yeah. That's
Any more books?
is that
Any more books?
no. No more books. Thank you. Okay. All right, I'll do that. It seems like I have a delay. Is that okay? All right. Thank you.
Thank you, Congresswoman Barragan, for your remarks and for your continued leadership. Hello, everyone, and welcome to our live stream event on addressing minority health disparities. I am Clorinda Wally, president of Good Days, a national nonprofit that lifts the burden of chronic illness through assistance, advocacy, and awareness. Okay. Okay. And so also I'm never on mute, correct? Okay. I know yesterday we talked about it and you're like, okay, they're going to be able to hear anything you say. So just want to make sure. Okay, perfect. Perfect. Okay, I can do that. Uh-huh.
Thank you to the patient advocates and public health advocates with us today. It is my pleasure to welcome you to the annual Chronic Disease Day Health Equity webinar in recognition of Minority Health Month. My name is Congresswoman Nanette Diaz-Barragan, and I represent California's 44th District. I serve on the Energy and Commerce Committee, which has jurisdiction over healthcare issues in the U.S. House of Representatives. Thank you to the patient advocates and public health.
Okay. So the first thing that comes up, it's the video, and then I'm going to say thank you, talk about the live stream, introduce myself, and then I will go into the interview with Melody.
Thank you to the patient advocates and public health advocates with us today. It is my pleasure to welcome you to the annual.
And then, so it's counting down, it's not playing anymore, so I don't start talking until that goes to 0? Okay, all right. Okay. And then the questions, where's Melody's question?
Thank you to the patient advocates and public health advocates with us today. It is my pleasure to welcome you to the annual Chronic Disease Day Health Equity webinar in recognition of Minority Health Month. My name is Congresswoman Nanette Diaz-Barragan, and I represent California's 44th District. I serve on the Energy and Commerce Committee, which has jurisdiction over healthcare issues in the U.S. House of Representatives. In this capacity, I work with my colleagues to advance policy to promote healthcare access, address health disparities, and enhance diversity, equity, and inclusion initiatives. As a member of Congress representing a district that is nearly 90% Latino African American, the issue of racial health disparities and working to close the healthcare gap are among my top priorities. Earlier this year, President Joe Biden signed my first standalone bill into law, the John Lewis National Institute of Minority Health and Health Disparities Research Endowment Revitalization Act. It provides funding to academic institutions across the country for research and critical work to reduce health disparities. I also look forward to working on an annual efforts in Congress to increase funding for programs that can reduce minority health disparities. This includes funding for minority health and health disparities research at the National Institutes of Health, expanded healthcare coverage for mental health services, and funding for grants focused on social determinants of health at the Centers for Disease Control. Thank you again for including me in this wonderful event. It sounds like there are some great speakers here today. I will close by saying this. Your story and your voice have value. Your members of Congress appreciate the opportunity to hear from you about challenges and progress in your healthcare. Your advocacy and personal feedback help us shape policies that move us one step closer to ending the disparities in public health. Thank you for having me.
Thank you, Congresswoman Barragan, for your remarks and for your continued leadership. Hello, everyone, and welcome to our live stream event on addressing minority health disparities. I am Clorinda Wally, President of Good Days, a national nonprofit that lifts the burdens of chronic illness through assistance, advocacy, and awareness. Before we begin, I want to extend a special thank you to more than 24 national nonprofit organizations who support Chronic Disease Day activities through the Chronic Disease Alliance. Together, we will drive meaningful change on behalf of the chronic and rare disease communities. We have a great lineup today, and we're going to hear remarks from Dr. Louis Sullivan, President Emeritus of the Morehouse School of Medicine and former United States Secretary of Health and Human Services. Dr. Loretta Christensen, Chief Medical Officer of the Indian Health Service, and community leaders and heads of national advocacy groups across the country. To kick off today's event, I am happy to welcome to the stage Melody Narian Blackwell, founder of The Color of Crohn's and Chronic Illness. Hello, Melody.
Hi, Clorinda. Thank you so much for having me today.
Oh, thank you for being here. So I'd like to just start with a little bit of a Q&A. So just to begin, can you tell us about the Color of Crohn's and Chronic Illness and how you came about starting that organization?
Absolutely. So we launched as a Facebook group initially in 2018. I had been going through symptoms for over 25 years, honestly. And when I finally got diagnosed, I took it upon myself to do my own PSA. I said, okay, let me just share this because I had followers as an entrepreneur and I was coaching other entrepreneurs. And I said, they need to know what this looks like because we want to prioritize health in our mission or efforts to create wealth. When I shared that, I started getting DMs. I had a huge influx of messages of people telling me that they were either the first person of color, the first Black person to ever be diagnosed with the disease, that they were the only person of color being diagnosed with the disease, that they had family members who had presented similar symptoms that I had been sharing through the last year, and they wanted to engage and connect. I loved responding, but I recognized quickly that I couldn't manage all of this in my DMs. I was a mom, wife, owned a restaurant at that time, and I was coaching my clients. I said, I'll move this to Facebook. I moved it to Facebook to create a group so that people could find each other. So some of the questions that were being answered, they could be right there in a group so people could refer back to previous posts. Unbeknownst to me, I created that group and then I was overwhelmed, thinking that my story was an abstract or an anomaly. It wasn't. It was a pattern. It was extremely consistent. And to be honest with you, it was probably one of the less harsh ones. And once I was exposed to these stories, I tried to help. I helped with copays, buying groceries, taxis, parking. And I recognized that that just wasn't enough. And I went from a person that was completely committed to Nordstrom return policy to learning what it meant to advocate for my community. And from there in 2019, we applied to become a full-fledged 501c3, and that is where we are today.
Well, I mean, what an amazing journey for you. And, you know, as we spoke a little bit in our previous call, autoimmune diseases just show up so differently. It can be the exact same condition and just so many different symptoms,
Yes.
which is difficult.
Yes.
So can you talk to me about why health equity is important when it comes to chronic and rare conditions from Crohn's?
For all communities, health equity is important, right? It's so, you know, that is just what we all deserve, especially when it comes to rare diseases and chronic conditions, because we find ourselves not sharing with our physicians because we don't trust them. We don't think that they hear us or see us. And these diseases have a smaller lens. They're not diseases that people easily recognize when it comes to Crohn's and ulcerative colitis, especially communities of color, because we don't associate stomach aches and chronic symptoms with disease. We think it's just par for the course of not having the right diet or not being exposed to the right opportunities, but it's not. It's much deeper than that.
Yeah, and I also found from the Latin community perspective, it's like you get over it.
Yes.
Oh, it's just a stomach ache. You're
Yes.
going to be fine. And so it's like perpetuates, you know, generation over generation.
Yes.
And so
Yes.
I think it is now is the time to start, you know, making change.
Absolutely.
Or
Absolutely.
saying, you know what, if you're not feeling well, it's okay to see a physician. It's okay
Yes.
to seek answers.
Yes.
So can you talk to me about how the color of Crohn's addresses disparities in treatment patterns and health outcomes in specifically the minority populations?
Absolutely. One of our first priorities is to open the space for people to talk and feel. It's okay to feel. It's okay to talk about this. It's okay to say that you don't feel well, because what happens usually is their family members aren't exposed or their friends don't understand that they're dealing with these symptoms and they get tired of hearing them. Or the patient, like myself, we get tired of sharing that because we don't want to say every single day, I don't feel well. So the first and most important thing we do is allow people to exist where they are. Secondly, we empower them with tools to have conversations. We have a guide that I created when I first started coaching called Confident Conversations. So we lead you with questions that you can ask, because when you're new to having to navigate disease and you're having to navigate so many doctor's appointments, you often hear so many things that you never hear. You hear it, you don't ask questions, you don't know how to follow up, you don't know what you should be asking. You're hoping that the physician will give you everything that you need and then you can run with it. Not always the case. So we allow them to feel, we empower them with questions, but we also put them in front of providers, kind of dismantling this inferiority superiority complex that communities of color have often faced, because we respect the white coat, we respect authority. That is a structure of historical, structural racism, because we don't challenge those who we feel are superior to us when we're just as powerful as patients as the provider is as a provider.
So, and, just looking at my own journey, it was always difficult. So I was told, take children's vitamins, it's just you're just a little bit anemic.
Yes.
So again, I think finding the road and the path to just figuring out what is wrong with you certainly has far more challenges, I believe, in the minority communities.
Yes.
So how does the color of Crohn's help to mitigate risk factors that can lead to developing or worsening chronic illness?
What's interesting is that often our community members have shared that they didn't know something was wrong. They don't understand that disparity sometimes means a big difference. And our treatment and our diagnosis has been a huge challenge because that's the big difference. So we have created programming around research opportunities. When you look at the research when it comes to IBD on communities of color and traditional research, it's few and far between. Disparity. When we look at the platform or foundation of drug deliverance, disparity. When we think about how many drugs we get to before we can actually get to baseline, going through traditional pills to biologics, disparity. And we teach them, we educate them, we open the field space for them to feel like their voice matters. And that's how we have empowered them to become advocates, not only in their doctor's appointments, but for the community. Our community, which has over 600 people in them, there's conversation and discussions going on all day long. So they're empowered with themselves within their community to mitigate what kind of care is being delivered to them.
And I think, part of being in a community like that, it helps you to figure out what is normal.
Yes.
So, if you go to a provider's office and you're talking about these symptoms and those symptoms aren't being recognized, you start questioning yourself. Well, are they real? Like, is this happening to anybody else?
Yes.
So I think, community conversation is very important. Again, just to figure out, am I normal?
Yes.
In whatever condition that I've got.
Yes. And, Clarinda, we've even taken that a step further when we launched our HBCU program. So we have an HBCU program where we're actually going to campuses. We're educated on IBD, mental health, clinical research. We're teaching them about language, importance of IRB, the importance of informed consent. So we're not just doing it with those who have IBD, but awareness is multi-generational and multifactorial. And we're really committed to doing that to change the landscape of what IBD has looked like historically.
Oh, absolutely. So what kind of tips do you have for people who want to be an advocate, who want to advocate for themselves and their health condition?
I always think the most important aspect of this journey is plugging into community, whatever that looks like for you, especially those who understand the lived experience with your disease or journey. Plug in there because it's empowering. And you also learn from so many others that have navigated this previous to your navigation, but they'll support you and they'll say, yes, that's okay. Take the day off, take the time where you might've heard you're lazy. You're not committed to this. Community says you're committed to making sure you live to the next day. So join in with us, connect with community, get the support first. And that support will take you over the hill and shoot you to the sky.
I 100% agree. So coming together when we were first thinking about what we can do to help people suffering with chronic illness, we also started as a Facebook page. I think we might've had 8 followers to now coming. And so as people understand what you're committed to, what your priorities are, and they find likenesses and cohesion, the more people, the louder the voice, the more apt to get positive change. So, I just want to thank you for all the work you're doing. And is there anything else that you want to leave us with?
I want to leave you with knowing that we are not only creating awareness and change and advocacy for our community, but we're also empowering them to understand that policy is for the people. A lot of times our communities associate with policy with the justice system. And we know that in Black and Brown communities, it has been a terrible injustice historically and presently. So as we empower them to understand that policy is for the people, I believe that as a chronic illness community as a whole, we will shift and create opportunities that are better for us all, a better healthcare system for everybody.
Absolutely. I look forward to those continued changes. So again, thank you so much. We truly do appreciate it. And I hope that we can continue to connect and partner to make positive change. Thank you, Melody.
Thank you so much.
Mm-hmm. All right, well, for our next segment, I'm pleased to welcome Dr. Standifer of the Morehouse School of Medicine to the stage.
Hello.
Hi there, how are you?
I'm great, how are you?
Doing very well. Well, thank you so much for being here.
Great, well, thank you. And I'm just elated to be here on this panel today and moderating an excellent and illustrious group of panelists this afternoon. I would like to start off with some housekeeping notes, just to highlight that I'd like to let the audience know to share any questions on Facebook, and we will bring them up at the end of the session. Okay, and again, I said I'm anticipating a great discussion this afternoon to highlight our illustrious, again, panelists. We have Deborah Frazier, the CEO of Choose Healthy Life. We have David Backelman, CEO of National Pancreas Foundation, and Norma Marti, co-lead at North Carolina Community Engagement Alliance. I'd like for them to go in that order, introduce themselves, and also what they're doing to help be an advocate for health equity. Ms. Frazier, okay, you're muted, okay. Thank you.
I'm Deborah Frazier House. Thank you so much, Doctor. I'm Deborah Frazier House, and I am the founder of Choose Healthy Life, which is a program that focuses on the Black church, where we allow public health navigators to work full-time in the church and connect the community to care. It was specifically created around the response to COVID, where we had testing deserts and the inability to get vaccines in some of our communities. We have some of the most powerful Black ministers in the country that have stepped forward in their communities. We started with a funding partner, Quest Diagnostic, and we started funding 50 churches in 5 cities: New York, Newark, Atlanta, Washington, DC, and Detroit, Michigan. We grew with the help of funding from HRSA from 50 churches to 120 churches in 13 states. We vaccinated and tested over 100,000 people, but we've had over 17.8 million people that we've touched, either through direct contact, email, the navigators going out into the community. They do a surface, a review, data check on 50-mile radius of each of the churches. They know where every beauty parlor is, every barbershop, everywhere the community congregates. They can tell you every church, everything. And they've gone out and created those relationships and brought the community in. And that's how we vaccinated so many when it was so difficult to vaccinate people. This program was created. I created this program based on my years of work in AIDS. I am also the founder of the National Black Leadership Commission on AIDS, which I founded and ran nationally for over 21 years. I was retired for the second time in my life when I found, I was watching them put Black bodies in Black bags in the back of Black refrigerator trucks. And I just could not stand it anymore. The first segment, people use the word normal a lot. And my focus is that we can't go back to normal because we died in normal. So normal is not good for us. We will refuse to do that. And we will advocate and fight with great resistance against returning to normal.
Well, thank you. Now we'll have David.
Good morning and good afternoon, I guess, based where you are in the United States. But thanks for having me and the National Pancreas Foundation to be part of this panel. And the National Pancreas Foundation is the only national organization in the entire country that impacts all forms of pancreas disease: pancreatitis, pancreatic cancer, FCS, and pediatric pancreatitis. So we're extremely proud of the impact we have throughout the United States. Regarding pancreas disease, it is much more common in minority populations regarding health disparities. And there's a few reasons for that, but pancreatitis and pancreatic cancer is 3 to 4 times more likely in the African-American community than any other minorities throughout the country. Although eventually over time, the National Pancreas Foundation will be looking at additional ethnic groups and minorities, for the next 24 months, we will be partnering with Webmd and CRAMES to develop a Black African American initiative, which actually is being launched May 1st throughout the country. It's our hope that not only the incidence, but the mortality rate of African Americans with pancreas disease is also 3 to 4 times more likely than the general population. Our initiative is a multi-pronged approach, really based on education and awareness to decrease the incidence of primarily pancreatic cancer and pancreatitis. The first asset that we're launching going into next week, it's called the DigiReach Guide. It's a 32-page electronic brochure, which sounds 32 pages is a lot, but it's actually a narrated electronic brochure with links and resources to videos, brochures, just everything that impacts pancreas disease. So we're really excited about that. Going over the next 3 to 4 months, we're going to be launching a really aggressive social media campaign in key cities throughout the country. Again, looking at education and awareness in the African American community of what the key causes of pancreatic cancer and pancreatitis are. So we're really looking forward to moving the needle. We know, as every panelist will talk about in minority populations, it's access to healthcare, especially in rural communities throughout the country, that really affects healthcare in the United States. And it's no different with pancreas disease, especially in rural communities. So a big part of our initiative is looking at rural communities and not only educating patients, but also educating medical doctors how to better diagnose pancreatic cancer, and especially pancreatitis, which is often not diagnosed or misdiagnosed. But there are a number of key factors regarding the incidence of pancreas disease in the African American community, again, which is our first stage of looking at minority health disparities. And a few of those components are hereditary risk factors, smoking, just poor diets due to food deserts throughout the country, obesity, and diabetes. We're in conjunction with African American Initiative, the National Pancreas Foundation is launching the first patient registry that impacts all pancreas disease. That will be launched at on May 22nd, actually, at DDW, which is a national, international GI conference. So we're really focused on the African American community, driving them to clinical trials and really impacting the rate of pancreas disease. And my last comment is that we know the only way we're going to take this scale and really to move the needle regarding pancreas disease is through strategic partnerships throughout the country. In addition to CRAMES and WebMD, we will be working with the Congressional Black Caucus, and we're currently reaching out and working with 30 national organizations, whether they're university systems, whether they're medical associations, whether they're Concerned Black Clergy, 100 Black Men of America, but just other partner organizations that can take our collateral and assets and really distribute it and impact some of the constituents that you're working with. So with that said, with all of our viewers, that if you have some interest in working with the National Pancreas Foundation, please contact me at David at pancreasfoundation.org. So thank you again for having us with you.
Thank you, David. Next up, Norma.
Hi, good afternoon. Buenas tardes a todos. I am Norma Martí, and I'm here representing the NCCL, North Carolina Community Engagement Alliance, which is an NIH, National Institute of Health, funded project that started due to COVID, right? Last year. There are 23 states that have Nccl programs across the state, all of them aimed at reaching, messaging, and vaccination rates and improving health outcomes for people of color and minority communities, particularly historically marginalized populations. I last year represented the community response team of Latinos, Hispanics here in North Carolina. As we all know, COVID disproportionately affected communities of color. Deborah's comment on Black bags for Black family hit home. Because again, in a city like Durham, North Carolina, where we have, as a state, we only represent 10% of the population. 75% of the people that were in the Duke healthcare system at the beginning of COVID were Latino. And so that was the biggest, just kind of shocked everybody into like, what are we doing and what can we do differently to get this messaging out? Not to say that, again, I was retired and was called back to work at the state when COVID hit. We tried to do messaging. We tried to get the word out. We did the best that we can. And I applaud the work that the North Carolina Department of Health and Human Services did. But what Nccl allowed us to do was to bring people from the community together. And that is, I think, the key to health disparities. It's until you have the voices of the people that are directly affected by whatever disease, whatever pandemic we're trying to solve this week, you're not going to know what to do. You're just not going to know what to do. And so our team comprised of just 10 folks, but again, strategically placed across the state, representing a variety of, you call us Latino, you call us Hispanos, but we're really a mixture of 23 countries that ended up somehow in the United States, or our ancestors, or our parents, or our grandparents. And so our cultures are very distinctly different. So it was important that that group represented the 10 people, at least 10 different national origins of Latino. Yes, we all speak Spanish, but it's really a very different cultural perspective to do that. And in so doing, and then regionally, of course, our rural folks are not the same as our Durham and Raleigh and Charlotte metro areas experiences. We have access to healthcare systems, right? But if you're in rural North Carolina, you don't have that local hospital that you can just drive up to. You got to go to the county next door or 2 counties over. And so those issues, again, had to be addressed differently and distinctly. And this group of 10, I call them my heroes for the last year. They really said, Norma, we've got to do it differently. We cannot have these messages that come out like, with all the words and all the statistics and the bar graphs. And I mean, that's nice, but real people don't talk like that. And how can we get the information that we need to get out? And I'll have to tell you that right now, and I'm not taking credit for this or our team, it was a statewide effort by lots of different community-based organizations, but our team did touch a pulse that I think really hit and resonated with our community. And that was creating 14 animations in conjunction with Arizona State University and University of California at Merced that are online. They're accessible. They talk about all the little, those myths, otherwise known as falsehoods, that have been out in our community from day one with COVID. So these animations were just, they just wildfire. People love them. They could post them. They're quick. They're all under a minute. Beautiful. Then we got the great idea that we should make them into cómicas. And so these 2 pages, double-sided, folded in half, cómicas of the last 7 animations have really been a hit in the community, not only because we did them in English and Spanish, but because the words and the concepts are very simple and at least hit the nail on the head, right? If you think that there's a chip in this vaccine, well, we're going to tell you that there isn't, and this is why, right? And in very simple Spanish and very simple characters that we could resonate with. So, Doctora Susana, Mama Lucha, which I kind of related to, the abuelita in the house. All of those characters have lived through the different stages of COVID. And currently our program at Nccl is refunded. And we're looking forward to collaborating with our African American and our Native American CRTs. We combined them. We decided that, together we're stronger. So we're going to work together this next year to see what kind of messaging we can create for where we are in the pandemic. We are still in the pandemic. What are we still needing to do? What treatments are available? How do we get folks engaged in clinical trials, given the historical, tragedies that have happened in all of our communities, right? So I'm honored to be on the panel, both with Deborah and David. Again, they're national, they're big. We're just this little group of us working right here in North Carolina, but really excited that we had an opportunity to do this work.
Thanks to you all. I mean, it's just, as I said, illustrious panelist here. I thank you all. We are awaiting questions. So anyone in the audience, please share your questions on Facebook. We will ask them, right? And I am just, I'm honored to be in your presence. All of you talk about, hey, I'm in a small area, the small, area of the country, and I'm doing small things, but it's amplified beyond what you even think about, right? As you're talking, Norma, what's happening in North Carolina and what occurred, 75% of that population being of Latina, it's like, whoa, what has happened? What is going on? It should not even occurred, correct? And so that gives we need to have restorative, factors that are there. And how do we culminate all of these efforts in terms of advancing some of the efforts and amplifying our efforts, right? We're doing that right now as we're talking live, but then how do we connect with the community and sustain what we have, right? Beyond, we've learned so much from COVID-19, but to sustain these efforts, as David talked about, even going into the community of pancreatic cancer. How do we prioritize those efforts when we're talking about, other cancers that often may be more, more in our face? Mm-hmm. But pancreatic cancer is something that is disparately impacting communities of color. And so how do we prioritize the education, the training, right? The informing of what's happening to our policymakers and to our community, and to what Deborah highlighted of the Black and Brown communities going into Black bags. What is that saying? How significant is that? And how do we kind of, it's talking about the stories and the daily lived experiences of those individuals and who were in those bags. And we know that their lives haven't been lost. It's not in vain, because what you are doing, Deborah, is amplifying their message. And we're continuing those efforts regardless. And you all talk about very small impacts, but you're making a big, huge difference in terms of, definitely advocating through those lost lives, through those marginalized, voiceless, Black and Brown lives as well. So I honor you and I thank you for doing that. And my question is, I guess, in terms of, I like, Norma, what you talked about and the creative and novel, pieces of, marketing and promotion that you're doing. Were there any challenges or barriers that you confronted and you had to kind of, okay, let's reevaluate this? Because I think people need to understand that this journey isn't easy, right? Mm-hmm. The work isn't easy, and it won't be done just, from those pamphlets. But what did you encounter in terms of your lessons learned?
Well, I think what we learned the most in our group was the collaboration. And again, the importance of nonprofits, wonderful health systems. I'm not going to, we have a great network of 3-4 major health systems in North Carolina. And they did the best given the circumstances, as we all know, COVID. We're building the plane as we were flying it. But you can't reach the community through a health system. But you can reach a community through the folks that they know that look like them and talk like them. And so, partnering with, again, each of our representatives on the team came from a different community. 503(1)C, they represented a group of other folks in their counties, in their area. So that was, I think, the first lesson that we learned, that you have to give those community-based organizations leverage, a voice, funding, so that they can actually do the work, because they're doing the work. They aren't always being funded. And again, Deborah's example of navigators and Black churches, I'm old. I've been around the block a long time, but I remember Black churches in the 1980 census is what got us counted probably for the first time in 200 years. And so again, it's getting those on the ground folk that know the community, that speak the language. Again, and I'm not just talking Spanish here. We have a huge number of refugee and immigrants who, again, we cannot ignore as a community and in health systems. And not going back to normal. I agree with, again, Deborah's comment. No, normal was not good for us. In North Carolina, we have 23,000 people that die. That is not normal. on a given year. So we can't go back to normal. We've got to change the system in some way so that people do have access. And I dare say that one way that we could do it, and we know because it worked during COVID and it's worked other times, is this concept of navigators or community health workers or promotoras de salud, which we call them in my community. Those promotoras are my heroes. Those promotores, they will go every Saturday, Sunday, Monday, Tuesday, Wednesday, Thursday, 8 o'clock, 9 o'clock, 10 o'clock, midnight. They're taking people places, they're getting them vaccinated, they're explaining to them on the phone why it's important to get vaccinated, why your child should get vaccinated, and they don't always get paid.
Mm-hmm.
And so if I'm doing the work for your health system, please pay for my what I bring to the table. You know, it's a branding thing, and we do it for sports. You know, we do it for all kinds of other things. You know, you may not know that Norma Martí is somebody in North Carolina, but people in the community know that Norma Martí is somebody in the community, and that I genuinely have dedicated my life, but my children will tell you I've ignored them many times and prioritized the community, because it's so important that those of us who can speak on behalf of the rest who can't. And so again, bringing those community health workers up, promotores de salud, navigators, ambassadors, whatever you want to call them, as part of not the healthcare system, but funding them through community-based organizations so they can be the bridge. Right? They could be the bridge. They can explain what the health system does to the people and what the people need to the healthcare system. That's, I mean, if that happens in my lifetime,
Excellent.
I'll be happy.
Excellent. And sustaining that, as you mentioned, using those natural assets, they're already doing the work. People are already doing it, as Deborah mentioned, you know, using those natural kind of assets, you know, we sometimes don't even think about. And to me, Norma, I say they're part of the healthcare system to me, as I work with beauty salons and barbershops and churches and, you know, those places. Now, so they're part of the community. We're captive, right? The community is captive. So why not incentivize or pay whatever you want to say, but they're natural assets to the communities.
And
so
clients of those healthcare systems are our neighbors.
Yes.
They're our neighbors, right? They're not, the healthcare system doesn't only take care of people that work in the healthcare system, they take care of all of us, or should.
All of us.
And
all of us. So thank you. Thank you. Okay. There are questions just quickly for David. Okay, there's a question for you. Can you tell us more about how the National Pancreas Foundation will work with WebMD to address current disparities in minority care?
Yes, thanks for the question. And we'll be contracting with WebMD, with their social media group, to partner on pushing our information out, meaning education and awareness campaign throughout the country. We're going to target African-American communities or the largest cities in the country, the top 20 cities, to really have a targeted approach. It is a paid agreement that we have with WebMD, but quite frankly, having a nonprofit rate is beneficial for a small national organization like NPF to have the impact that we expect in the scale throughout the country. So that's how we're working with WebMD. Also, the beauty of the partnership with WebMD, with their social media group, that will be guaranteed over 100,000 hits on social media a month. And so when you look at the economies of scale, as Norma was saying earlier, the way to take things to scale really are through strategic partnerships. So for a very little money in contracting with WebMD, you know, over the course of a calendar year, we'll have a minimum of 1.2 million African Americans that will learn about pancreatic cancer and pancreatitis. And again, our end goal is really decreasing not only the mortality rate, but more importantly, the incidence of pancreas disease in the community that we're focused on.
Great, great. I think that's very key. And so I don't know, how did that emerge, David? I guess to even expound upon your collaborative efforts with WebMD.
Yeah, well, in our 25-year history, NPF has had a huge impact throughout the country on a general basis, primarily with pancreatitis and pancreatic cancer. So our board of directors wanted us to really go down 2 or 3 levels of where we can impact really communities throughout the United States. And, we started working on this actually before the Biden administration went to DC. It's literally taken us 1.5 to 2 years to get some partial funding for this initiative, and also to get the key players throughout the country to work with us to make sure we can have the impact that we have. So it's our goal to look at other minority populations, but we knew that we couldn't take everything on immediately. And so, first we're working on impacting the Black African American community. 2 years after that, although we'll still be working on it, I'm sure that we'll look at the Latino and Hispanic community. But that's how we looked at it. We're looking at how can we take a national organization through strategic partnerships and really impact communities on the grassroots level. And I think that's the biggest challenge with a national organization with a limited number of employees, is how do you have the macro design of an initiative, a program, but how do you get it on the grassroots level? And again, as I alluded to earlier, the only way we're going to do that is through strategic partnerships throughout the country.
Great, thank you. Very key in understanding those strategic partnerships and how to navigate, and in terms of sustaining those efforts. And we have another question for Deborah and Norma. What is it like to engage directly with folks on the ground in your communities? I think I know, I think I can start probably, it's going to be rewarding. I'm going to hear that. I'm going to hear it can be challenging, but also, I think, like you said, very fruitful, of course, and you learn so much, as Norma highlighted. But let's talk, you can start with Deborah. What is it like?
It can be challenging.
Mm-hmm.
But let's say this. It all depends on how you see the community.
Mm-hmm.
You have to come and you have to be authentic. The government, per se, federal, state, all the government entities are going to have a problem organizing the community with business cards from the government. The government has sort of lost control of their respect. And COVID made it much, much worse. You have to go to the community, be where the people are, but you also have to respect them. You have to respect that, as Norma said, that they should be supported and resourced for the work that they do. Respect their voices. They know more than you do, Mr. and Miss Public Health, about their own community. And you have to let them be authentic, and then you have to be authentic. I tell a story about this young man who was introduced once, and the people were saying that, oh, he's introducing him. The people that were introducing him were saying things about him that showed his struggle in life. And the last thing they said, and he comes from a fatherless home. And the kid got up and he said, let me just correct one thing. My home is not fatherless, it's motherful. So it's the notion of respecting people where they are and the way people feel that there's nothing wrong with our communities. Our community has the resources it needs and everything else that it needs to take care of itself. The public health system is there to help them along in doing that and should be there to expedite what it is and resource what they need, but they don't need to be there just to tell them what to do. So I think that that's a lesson learned. I think the other lesson learned is, and this is to the public health community, it doesn't matter what you call it. You call it health disparities last year, you call it health equity this year. If the outcome is the same, we don't want it. So it doesn't matter what words you use if the outcome has not changed. And the outcome changes when you go into the community, you respect the community, and you let the community come up with some of the solutions. You use authentic data. We believe in data. Tell us the truth, but don't not count us and then tell us that everything's going to be okay. It's a perpetual level of disrespect. And I think that what you see now is that people realize we've watched it kill us for a long period of time. And we keep writing these papers and these reports that go on the shelf. And everybody knows what's wrong. Everybody knows that there are health disparities. We're 3-4 times more likely to do this, 3-4 times more likely to die from that. Everybody knew that before COVID. So what's the solution? Whatever the solutions have been up to date, they didn't work. And they worked more miserably when we got to COVID. So respect the community. Let the community make some decisions for itself, resource those decisions, and let them move forward.
Excellent.
It's
Norma,
not as hard as you think.
I don't know. I think Deborah nailed it. Just like what else can I add to that? I think again, it's listen, it's resource. It really is. There were millions of dollars poured into communities for COVID. How many of those millions actually reached the nonprofit grassroots folks? And I have to say that I am a public health professional, so I have to say that some of us in the public health world just, did the best that we could given the resources that we could in March of 20, April of 20, March, September, and I kudos to North Carolina, because the state of North Carolina funded community health workers. It took till September, but at least they did fund it. And today we are actually, if you look at the Latino vaccination rate, we're the highest vaccinated in the state. So yeah, something worked. Some all of us getting together, all of us being resourced for whatever little bit we got resourced, did make a difference in our community.
Sure.
How do we continue that and then not make it feel as if, and this is why our team has come together instead of having 3 separate teams, because it's not about fighting for those dollars, whether it's Black, brown, white. We're all in this world together. And until we learn that we're all human beings, every last one of us loves, every last one of us wants to be loved, and every one of us wants to help. And so figure it out. I mean, don't research us anymore. Don't research us anymore.
I agree. And I want to add something to what Norma is saying. Don't come in and throw money at us in an emergency and then walk away, because that's where we are now. And that's why the mantra has to be, we will not go back to normal, because normal is the place that we died. Don't come in and help us. I am a public health professional, but I'm a public health professional that's fed up with what I'm seeing, because as Norma, I'm an authentic public health professional. And you can see what works. We can tell you what works. So coming in now and then walking away, we have 120 churches in 13 states. So we're back down to the first 10 cities we were in. Why? Because the money's gone. And all of these people had 1,500 hours of training. They're certified. What do we do with this now? We just walk away from it? It's absolutely absurd. We're in fact coming together to meet with the CERA to ask them to create an innovation fund, a public health innovation, a community level public health innovation fund, something like the MacArthur Foundation, where when you see innovation, you respect it, you fund it, and you sustain it. You don't walk away from it. And I think that's one of the things that's missing in our whole public health system. Where is the innovation fund that really allows us to move forward?
I like that.
You like that? Good.
Thank you. Thank you. For all of you for being authentic, committed, definitely, right? And very transparent, as you have to be when we're working with communities, right, that are impacted. You have to be transparent. I am you, you are me, and we are in this together. And that is just one step on how to sustain and how to move. We know COVID-19 brought so many things, right? But I saw more so looking even at my academic and community partnerships, even looking at my own personal family, is that it kind of lit a fire under so many people. Like, this is unjust. I won't stand for it. And I have to do something within my own power, whether it be in my own church, in my own, barbershop, in my own beauty salon. I have to be there. In my own bodega, there are so many other, elements that we need to make sure that we are there and we just continue to amplify the message. And so I thank you all for highlighting what needs to be done and that you are continually being committed and fighting for those inequitable solutions and continue to work with those who are around and those who often make decisions. And so we know that those are policymakers, whether they're elected or appointed, but we know that we have the power and we need to talk with them. And we want to just say thank you and to please stay for current remarks from those federal government officials. And we will be right back. Thank you again.
Thank you.
Thank you.
I'm Congresswoman Brenda Lawrence, and I proudly represent Michigan's 14th Congressional District. I serve as the Vice Chair of the House Appropriations Committee, and I am a member of the Labor, Health, and Human Services Education Subcommittee, which funds federal health care programs on an annual basis. I work with my colleagues each year to support diversity, equity, and inclusion initiatives, and to enhance funding for federal programs working to address both health disparities and to promote health equity. It is a priority of mine on this committee and also in the Congressional Black Caucus, where I serve as a second vice chair. Chronic diseases, including heart disease, diabetes, hypertension, COPD, and many others, have a disproportionate and well-documented impact on communities of color and communities that are medically underserved. Through the fiscal year 2022 Omnibus Appropriations Package, Congress has shown a commitment to funding medical research in NIH and the greatly enhancing the investment in the National Institute on Minority Health and Health Disparities. There is also a strong emphasis on public health in the Omnibus package, with investment in the Ending the HIV Epidemic Initiative, the Social Deterrence of Health Program, and the Chronic Disease Education and Awareness Program at the CDC. But I know more work needs to be done. My colleagues and I plan to fight for these continued investments through fiscal year 2023 appropriation process. I understand you have some excellent speakers from the Biden administration today to discuss the ongoing and emerging health equity efforts from the Department of Health and Human Services and the Indian Health Service. I look forward to continued work with this administration to advance these health equity initiatives. Particularly, we must support efforts to improve access to health care and address the chronic disease and health disparities. Thank you again for having me open this event and for the opportunity to join you all.
Thank you very much to all of you who have joined us for Chronic Disease Day this year. We're very pleased to have as our guest Dr. Louis Sullivan, who is the President Emeritus at Morehouse School of Medicine, and of course, the former Secretary of the Department of Health and Human Services. I'm Dale Dirks, the Washington representative to the Association of Minority Health Professions Schools, which are the 12 historically Black medical, dental, pharmacy, and veterinary schools in the country. And Dr. Sullivan has agreed to join us today to spend some time talking about chronic health care conditions. The format that we'll have today is that I'll pose a question to Dr. Sullivan and he'll respond. And we've got 3 or 4 questions that we want to pose to Dr. Sullivan. And we hope that this will be instrumental and educational to everyone who is attending Chronic Disease Day. So welcome, Dr. Sullivan. And if you'd just like to say a brief hello remark, we can go ahead and get started with the questions.
Well, I'm very pleased to join with you and your colleagues today in recognizing Chronic Disease Day, because this is very important to improving the health of Americans as well as people around the world. So anything that we can do to emphasize ways to improve health, I'm all for it. So it's my pleasure to join with you.
Thanks very much. But Dr. Sullivan, you spent your entire career as a champion for improving the health status of all Americans, particularly minorities and those in medically underserved communities, as well as those suffering from chronic healthcare conditions. How have things changed in the last 50 years?
We've had some significant improvements in health status, as well as in treatment of diseases. And that's very encouraging, because I always maintain that having a healthy community or healthy individual not only leads to a better quality of life, but it also stabilizes our social system and strengthens our economic systems as well, because a healthy population is more effectively employed, less days spent disabled from illness. So that's really why that's important. So it's been a lifelong quest of mine to do everything I can to improve the health of Americans. It started really when I was quite young. I was interested in science, trees, birds, lizards, etc. But the important focus that I received was from our family physician in rural Southwest Georgia, Dr. Joseph Griffin. He was someone who could cure people from illness and injury, highly respected, very successful. And I knew by age 5, I wanted to be like Dr. Griffin. I wanted to be a doctor. So that started my lifelong quest. And it's been very interesting, challenging, but very rewarding all along.
Thank you for that, Dr. Sullivan. You were the founding president of Morehouse School of Medicine in Atlanta, and it's one of just 4 historically Black medical schools in the country. What role have the HBCU health profession schools played, and what role will they continue to play in improving the health of all Americans?
Well, the 4 HBCU medical schools have played an important role in improving the health of Americans in general, but particularly the African-American community and increasingly other minority populations as well, Latino, Native American, and others. Because of the 153 medical schools in the country, there are these 4 predominantly African-American. The role of increasing the health professionals in the country is that of all of our nation's health profession schools, whether they are majority or minority. But the minority schools exist because our nation has an unfortunate history of, first of all, slavery, then followed by segregation, discrimination, unequal opportunity. And at the beginning of the 20th century, we had very extensive legally enforced segregation around the country, particularly in the South. During the 20th century, with the civil rights movement, beginning in the 50s and throughout the 60s, a number of improvements occurred. Legislation that really ruled that we needed to open schools, hospitals, public facilities for all of our citizens to use. And that was enforced particularly during the 1960s with the civil rights movement, giving Blacks and others the right to vote. Also, the improvement of the access of women to positions of power, politically and otherwise, has been part of this. So all of this has made the health of Americans, and particularly minority Americans, improving. One part of that could be seen in the fact that in the year 1900, difference in life expectancy between Blacks and whites was about 15 to 17 years. For the white Americans, it was around 50 years, but for Black Americans, it was 35 years. At the beginning of the 21st century, we find that life expectancy overall for Americans is around 80 years. For white Americans, it's 82, 83 years. For Black Americans, it's around 78 to 80 years. So the life expectancy of all Americans has improved, and the gap between whites and Blacks' life expectancy has narrowed, but it's still there. So we still have a lot to do to see that the health of all Americans really is maximized. So that's the challenge that we have today.
Thank you, Dr. Sullivan. It's really interesting to note that the 12 historically Black health profession schools in the country have made such a significant contribution to the number of minorities in the health professions. It's somewhere around 50% of the Black doctors in the country, 60% of the Black dentists, 75% of the Black veterinarians and pharmacists have graduated from these 12 institutions. It's pretty daunting to think about where we would be in terms of health status had those institutions not been available to make that big contribution.
Oh, no question about it. For our history, we note that the first medical schools in the United States opened in the middle of the 18th century. Around 1765 with University of Pennsylvania Medical School, followed by King's College, which is now Columbia University, and then Harvard. But they did not admit Blacks. The first Blacks admitted to U.S. medical schools was about a century later, around 1847. And to come to the 20th century, we find that only 2% of Americans' physicians were African-American. That was the case up until the mid-50s, the middle of the 20th century, when the two predominantly Black medical schools, Howard and Meharry, provided the training of virtually almost all of the nation's Black physicians. Now that the nation's medical schools and other health profession schools are generally open, we find that many schools now have really undertaken the training of more diverse health professionals. But it's still far from where it should be, because today, only 5% of the nation's physicians are African-American, whereas African-Americans represent 13% of the nation's population. So we still have a lot to do and a long way to go.
Absolutely. Under your leadership, Dr. Sullivan, as Secretary of Health and Human Services, you created the first Office of Minority Health. Later, you were instrumental in establishing the National Institute on Minority Health and Health Disparities at NIH. How have these initiatives been meaningful in improving health status?
They're very important, and they have a lot of work to do. First, to address this situation directly, but also to provide leadership to the rest of our scientific institutions, the rest of NIH, the National Science Foundation, private foundations, et cetera. But the Office for Minority Health indeed was the result of first a study done by the Association of Minority Health Profession Schools. This was an association that was formed in 1977 that first included Morehouse School of Medicine, Meharry Medical College, Tuskegee Veterinary School, and Xavier College of Pharmacy. And then it's grown from that, as you've noted, to include 12 health professions programs at predominantly Black institutions. This study was presented to Secretary Margaret Heckler in 1983, showing the shortage of Black health professionals. As a result of that, Secretary Heckler commissioned her own study within the Department of Health and Human Services. That committee that was headed by Dr. Tom Malone, African-American biologist who was a deputy director of the National Institutes of Health. That committee came out with what was commonly referred to as the Heckler Report in August of 1985. It was titled Black and Minority Health. It showed these statistics in stark detail. As a result of that, the Office for Minority Health was created in the office of the Secretary. And then later, during my tenure as a Secretary, I created the Office for Research in Minority Health at NIH. That was in 1990. That office has now grown so that it is now the National Institute for Minority Health and Health Disparities. Focusing on health inequities, why do we have these differences in life expectancy? The greater incidence of heart disease, diabetes, cancer, other conditions, arthritis, in the nation's minority populations, particularly the African-American population. And what can we do about it? So a lot of it is access to care, getting rid of the residue of discrimination and unequal access, but it also means improving the health behavior of all of our citizens. And by that, I mean this. We know that exercise has a very positive impact in improving the health of the individual if you exercise regularly. The diet you consume has health impacts, so you need to have a healthy diet with the right amount of calories and protein, vitamins, etc. And you need to refrain from use of things such as tobacco or addicting drugs. You need to see that you're sufficiently hydrated. So that is important too. So improving one's health means not only having access to health care, but also one's lifestyle should be one that enhances health. If we are successful with that, then we will continue to improve the health of our citizens, and they will have a much richer, more fulfilling life, and they will also economically fare better because they will be more actively employed in the workforce.
You make several references to the Association of Minority Health Profession Schools, and of course, you're one of the founding members of AMPS. A book is being written about the Association of Minority Health Profession Schools and the positive impact that this one association has had in shaping federal policy to this related to the support for minority institutions and improving minority health. Can you share some details about this upcoming book?
Yes, this book will be published this September of 2002 by the Johns Hopkins Press. The title is We'll Fight It Out Here. It's a history of how these institutions came together to work to develop programs by the administration and the Congress, and to have them funded to address such things as more dollars for research in health inequities, more support for health profession students through scholarships and loans, more support for the institutions, such as programs such as the Research Endowment Program that the National Institute for Minority Health and Health Disparities has, and a number of other programs. It's been very successful with a variety of programs. Many of them not only are programs that are enjoyed by minority institutions, but some majority institutions as well are supported by these programs. So if we can improve the number of health professionals that we have, as well as improve access to health care, we will do a lot to improve the strength of our nation, social stability, economic prosperity, as well as the health status. So the association has played, I believe, an outsized role in bringing about greater knowledge of health disparities and strategies to eliminate the disparities in health status that are too common in our population.
Well, I can tell you that it's been a thrill for me to be affiliated with the Association of Minority Health Profession Schools for now 40 years. The book that is being written, you and Dr. David Chanoff are co-authoring the book, We'll Fight It Out Here. He was the author of the autobiography for Congressman Louis Stokes. Can you tell us just a little bit about the author?
Oh, yes. Well, David Chanoff is a very prolific writer. He indeed worked with Congressman Louis Stokes, late Congressman Stokes from Cleveland, Ohio. The book, his autobiography, I think, is titled Gentleman from Ohio. So Louis Stokes was the first Black congressman elected in Ohio, I think in 1967, and played a very important role with the Congress. He was a member of the Appropriations Committee, and we worked with him, and he worked with members of the association to address health inequities in many ways. But David Chanoff also worked with me in writing my autobiography, which was titled Breaking Ground, published by the University of Georgia Press in 2016. So David Chatoff now working on the book outlining the history of the Association of Minority Health Profession Schools really has played a very important role in helping to bring knowledge to the American public about this association and individuals in the association who are working to improve the health of Americans.
Well, I look forward, of course, to looking at the book when it's published, and I'm sure the people in the audience will as well. Dr. Sullivan, we very much appreciate you taking the time to join us today and to talk about chronic health care conditions. Is there anything else that you'd like to address before we finish up today?
Well, I would just conclude by saying we not only need more minority physicians, nurses, pharmacists, other health professionals, but having a diverse workforce really not only means having people who understand the various segments in our population, but it helps enhance understanding and trust and communication between our citizens and the nation's health professionals. The COVID pandemic that we have experienced over the past 2 years here in the country have shown how important effective communication and trust is, because there's been too much confusion, misunderstanding in public health measures that are needed to effectively fight this pandemic, including having people accept the vaccines that have been developed. Very effective vaccines developed in a very short time, a scientific achievement of great measure. But if that's not accepted and utilized by our population, that great scientific achievement really is frustrated by not being utilized by our population. So indeed, having a diverse workforce is important, not only in terms of opportunity for all segments of our population, but also utilization of the health system and trust in the health system. So all of those are important in improving the health of Americans.
Well, thank you again, Dr. Sullivan, for taking the time to join us. And I'm sure you added probably about another 1,000 people to your always growing fan club. We appreciate you taking the time today to join us.
Thank you. My pleasure. Good luck to all of you.
Thank you.
Hi, Dr. Loretta Christensen. So great to have you here today. My name is Justin Wilson. I'm really proud to have the opportunity to interview you on behalf of Good Days and the Chronic Disease Alliance as part of our webinar today. Welcome.
Thank you so much. I'm very pleased to be here, and I look forward to our conversation.
To kick off, could you tell us a bit about the role of the Indian Health Service, as well as your role as its Chief Medical Officer?
Sure. The Indian Health Service provides comprehensive clinical and public health care to 2.56 million American Indians and Alaska Natives. We cover 574 federally identified tribes, and we also provide technical support and advice for multiple compacted and contracted tribes under the PL 93-638 self-determination, self-governance law. So we have a wide breadth of care to provide across Indian country.
Wow.
As far as me, I am overall clinical and preventative services, public health services, and I actually oversee information technology as well. So again, I'm honored to work for the IHS and provide this care for our American Indian and Alaska Native population.
And what a large scope of work that it sounds like you have there. Can you tell us what health disparities do we see between American Indians and the rest of the American population?
Well, historically, the social determinants of health and the health disparities are very well defined for American Indians and Alaska Natives. And when we really look at them, these have gone on for quite some time and very much impact the health status of our population. Just for some small examples, food sovereignty and food security. Most of our areas are food deserts. People have to drive miles and miles and miles to get food, and then I'm not sure it's always healthy, healing food. So that impacts health. You know, we want people, food is medicine. We want to make sure not only are we taking care of them, but we're providing the other elements they need to lead a healthy life. Transportation, housing, access to care more because they can't get to the care. We try very hard to strategically place our facilities so people don't have to go very far. But when you put all these disparities together, it is quite challenging to have a healthy population. When we look at our statistics, we definitely see deaths at an earlier age. When we talk about COVID, it became very prominent that we were hit disproportionately to the other races and ethnicities across the country.
Wow. And it sounds like then what you're describing in terms of some of the largest barriers to care are just the ability to physically to get to a location or to access kind of healthy foods. Would you say that is the case?
Yeah, this is very, very true, because if you really look at our reservations and give you three examples, the vastness of Alaska, and where there we have what we call healthcare, stations or clinics in Alaska, and we have over 50 of them. And they're displaced strategically amongst the communities, where we really look at training community members to help us deliver care. And the program that they have there, we're bringing down to the lower 48, which is community health representatives and behavioral health representatives and dental health representatives that help us deliver care to these, I call them extreme rural areas. Navajo Nation, 27,000 square miles, Great Plains, over 20,000 square miles. And so are there roads? Are they accessible? And right now, can people afford gas for transportation? So it becomes quite challenging. We do our best to get the care out to the patients, and that is some initiative that's moving forward, is how do we get further out into the rural areas so people have quicker access to care.
Wow.
So these are challenges that we have every day, and we could throw in the natural disasters like fires and mudslides and tornadoes and hurricanes, and it is quite challenging.
Yeah, and COVID, which we're going to get to in a second, I'm sure adds another level of challenge. Before we do, though, you mentioned that IHS serves more than 500 federally recognized tribes. I forget the exact figure that you had said there. How does the agency navigate the cultural differences between all these diverse communities?
Well, we're at 574 now, but we do get occasionally new tribes coming in, so that number does go up a bit. We rely on what we call our areas. We have 12 regions or areas that IHS oversees, and each one is in these strategic areas in 36 states. So what they do is they have a relationship with the tribes within their area. It could be one tribe, it could be 40 tribes. And we do work with each tribe based with cultural sensitivity and appropriateness for that particular tribe. And you're right, it varies a lot, but we let that drive what we do, respecting that sovereignty and that ability to govern themselves and to determine what is culturally appropriate. And I believe we do an excellent job across the agency in being very, very respectful of that and incorporating that into our care. That's the way you succeed. There has to be that communication, it has to be that collaboration, and that sense that we share their community. And it has worked very well. And I mean, the ultimate challenge was COVID, to see could we put this all together, and I think we responded exceptionally well.
Yeah, communication and collaboration, of course, are key for responding to the COVID pandemic. Can you discuss a little bit more about how that specifically has impacted Native American communities and what the response has been?
Well, we actually knew ahead of time that if COVID came through this country, which we anticipated it would, we would get hit extremely hard. And that was very, very true. Disproportionately, we have had somewhere between 2.2 and 3.0 more cases than anyone else. We've had about over 3 times more hospitalizations, and at one time we had almost 4 times more deaths. I think what that that was the scenario we dealt with. We responded despite all the really proactive things we did. The general health status of many of our population just got hit hard. I think it would have been worse, quite frankly, if we hadn't put all this in place, if we hadn't had all the support that we had to get care out to people and testing out to people. We do thank, our tertiary centers that took our most critical patients. And I think we all learned, we evolved through COVID, and we certainly adapted as a population. But what was really interesting, when there came a mitigation, a weapon, if you will, when the vaccines were being prepared, very proactive, lot of leadership out there, a lot of communication, transparency, because remember, we had to build trust. We're at a point where we have to make sure that we're the Indian Health Service of the US government. Can we have all of these tribal members trust us that we are going to try to get them the best care? And that took work, really proactive work. And I think it went very well because we were way ahead of the vaccination curves for quite some time. We're finding it evened out now, but in the very early stages, this saved so many lives that we got people vaccinated early. Our hospitalizations slowly went down. Our deaths definitely went down. Our cases did go down, but we still have them. But I think that the fact that community-based response was so effective speaks to the strength and resiliency of the American Indian and Alaska Native population, which tells me with additional resources to start to mitigate these disparities, we have great opportunity to improve the health status of our population.
Makes sense, and glad to hear that there are some more positive outcomes that we're seeing as of late. Children and young adults are especially at risk of adopting negative physical and mental health behaviors that can last a lifetime. How does the Indian Health Service engage with younger populations to help them make healthy living choices?
Well, great question. And the Indian Health Service has a branch called Health Promotion Disease Prevention that is an exceptional staff. A lot of it is tribal, some of it's IHS, so we work very closely together. A lot of health surveys, a lot of evaluation of youth programs is done between the tribes and the Indian Health Service, looking for that vulnerability. We have early programs to prevent underage drinking that we work with other agencies. We have, we try to get them engaged in projects like healthy exercise, biking, things that will keep them occupied and focused in a positive direction. We work very hard on student pathways to get kids to want to be in health professions, public health professions, etc. Because we know that there's not a lot to do on a lot of our lands, so we have to provide that opportunity to engage our youth. A really interesting thing that I'll describe very quickly is there's a evaluation called ACE, which is Adverse Childhood Experiences. We tried to do this in some of our agencies a few years ago, and the problem is everybody scored the highest score. So that just tells you the rather toxic environment and the stressful environment that our kids are growing up in. So that really is incumbent upon us to create these youth treatment centers, these youth programs. And we do have a lot of school-based medical programs throughout the agency where we go to those sites and engage with the students and try to provide a spectrum of care to them all the way through adolescence. So we do really have focus on that. We need more, but we work very hard on that particular issue.
So important. Thank you for sharing that. What suggestions would you share with someone who wants to advocate for better access to care in their own tribal community?
Well, I think that it has to be, first awareness, what is going on in your community, what is available, make sure we're communicating all that to all the members of the community. Work within your community to have expectations. We want better access, we want to call one phone number, whatever it is. I believe very much in community feedback, and I enjoy going around and meeting the communities. I know you're going to get some feedback that that might not be completely positive, but that's how we make a better system. That's how we improve things. So I think that the communities have to have a voice, and to do that you have to work with your tribal leaders, your community leaders, and get together and say, this is what we found we need. And then meet with the facility, whether it's tribal, urban, or federal. We need that feedback. And I do definitely want people to speak up. We want to hear their voice. We want to integrate that into the care that we provide. And we want to be in a good synergy with our communities. So I speak up. We need to hear what you think.
So helpful. Thank you so much for your time today. Anything else that you'd like to share with our audience before we let you go?
Well, I just think I want to be very thankful to all of our tribal communities for stepping up to the vaccinations, for working so hard through this whole pandemic. Our frontline workers, exceptional. And it really is just thanks to everybody of our American Indian Alaska Native tribe, because they did it. they're the ones that were out there doing it. So much appreciation for that. And thank you for this opportunity to speak today.
Well, we extend our appreciation as well. Thank you for all your great work and for being with us today. And we hope to hear from you again soon.
Thank you so much.
Good afternoon, and thank you all for recognizing April as Minority Health Month with this annual Chronic Disease Day Health Equity webinar. I am Congresswoman Lucille Roybal Allard, and in 1992, I was the first Mexican-American woman elected to Congress. Over my 30-year tenure in the House of Representatives, it has been my great privilege to fight for expanding health equity, combating chronic diseases, improving women's and children's health, and advancing human dignity. As the first woman to chair the Congressional Hispanic Caucus, I have been proud to have been at the forefront of highlighting this country's dismal record of health disparities. And as the CHC Health Task Force Chair for several Congresses, it was my honor to have been the author of the Health Equity and Accountability Act in the 113th Congress, and to have fought for the inclusion of many of his provisions in the Affordable Care Act. Through my work on the House Appropriations Committee and its Labor, Health, and Human Services Education Subcommittee, I have fought for sustained funding increases for equitable health research, workforce development, and programs to improve the health of all communities, including infant and child care, prenatal health, dental care, HIV testing, substance abuse, diabetes treatment, and telehealth services. I also co-founded and co-chaired both the Congressional Public Health Caucus and the Congressional Maternity Care Caucus. In these roles, I have worked with my colleagues to prioritize robust investments in public health, establish the new Chronic Disease Education and Awareness Program, enhance the Social Determinants of Health Program, and ensure optimal maternal and infant outcomes for all women and families. I have always believed that healthcare was a right and not a privilege. As the representative for the 33rd, 34th, and now the 40th Congressional District of California, I have continuously represented majority-minority constituencies, and so it has been my topmost priority to ensure that all communities had access to the highest quality health care that was both affordable and culturally appropriate. I am pleased to see that the Biden-Harris administration is prioritizing health equity and health care access, and that the community is calling on Congress to address issues of diversity, equity, and inclusion. I appreciate the progress that has been made since I was first elected to Congress, but much more needs to be done. It has been the privilege of a lifetime to work with all of you on these issues over the last 3 decades, and I most sincerely thank you for your passion and commitment to improving the health and the lives of the most vulnerable among us. In my remaining months in Congress, I look forward to working with my colleagues and public health advocates to ensure that we sustain and increase the investment in efforts to address health disparities and achieve health equity. Thank you again for the opportunity to join all of you in recognizing Minority Health Month. I hope you have an excellent health equity event.
Well, thank you everyone for an excellent discussion. And thank you all for joining us for this live stream event in recognition of Minority Health Month. We hope you'll join us for our next live stream on Caregiving in America, happening on June 9th at 1 p.m. Eastern Time. Please visit chronicdiseaseday.org for more information and how you can get involved. Thank you so much, and I hope you all have a great rest of your day. Take care.